As we are talking about obesity, I need to define what we mean by obesity. So, overweight is the common term we use, that is, excess of expected normal from normal weight. That you call obesity. We can classify obesity with an index. Both WHO and Morbid Obesity Society of India had a classification. Both correlate little. Obesity index, or BMI, what we commonly use, is the weight in kg by height in meter square. So this is a fairly represents the risk and magnitude of the obesity in our scientific expressions or discussions. From this table, what I want to stress that Morbid Obesity Society of India has defined a ranking almost 2.5 index less than the WHO definition. The reason is in Indian subcontinent, but we are also included, people have high visceral fat, and there is central distribution of subcutaneous fat. And overall, the Asians are susceptible to the effect of obesity, and consequently, there is so many of comorbidities related to obesity. In US, probably most of the obese people are there, so they have more extended classification of beyond morbid obesity of beyond 40 to super obese, beyond 50, and then super obese of 60. I don't know how that super obese would look. But, you remember one patient from Egypt was taken to Bombay from with a cargo plane. She was rescued from her home on the first floor by breaking down the living room wall and lifted with a crane kind of thing and brought to Bombay. Ultimately, that patient could not survive anyway. So BMI is an indirect measurement. Only height and weight is considered, but weight gain from other regions like bodybuilding, those who are bodybuilding taking extra proteins and anabolic hormones, and there is some maybe collection of fluid in the body like ascites or anasarca kind of thing, or there may be some unusual large tumor representing a weight gain. So sometimes it may not correlate with the actual index. The body fat distributes differently in different genders. As you see, the pear and apple shape. It has practical significance also. The visceral fat, as it accumulates more in the trunk and the body, males, the visceral fat practically is an endocrine gland. One of the major hormone it releases is adipokines. In normal patient or normal BMI patient, adipokines is responsible for the sense of well-being, metabolism, satiety, normal cardiac and vascular endothelial functioning. But with increasing adiposity, more and more adipokines are secreted, and that leads to harm of the end organs like heart, vasculatures, and kidney. There is also some insulin resistance, hyperinsulinemia, or increased circulating free fatty acid, activation of the renin-angiotensin system, the aldosterone system, and sympathetic nervous system also. And there is some myocardial remodeling and some small vessel diseases also. So excess adipokines in the presence of hypertension, coronary artery disease, and type 2 diabetes mellitus cause a structural alteration in the cardiovascular system leading to left ventricular hypertrophy. And there may be some eccentric left ventricular hypertrophy also. With obesity, there is obstructive sleep apnea is a common thing. There is repeated hypoxemia and hypercarbia. leading to pulmonary hypertension, and right ventricular hypertrophy would be there. So this mechanical, metabolic, and hemodynamic effect produces at the end a congestive heart failure-like situation, what we call obesity cardiomyopathy. So in obesity cardiomyopathy, there is mechanical impediment to biventricular function. There are excessive fibrosis of myocardium and fatty infiltration of the myocardium and accumulation of fat and lipids in the cardiomyocytes. The other cardiovascular conditions that affects the outcome of a patient's survival is systemic hypertension, OSA, conduction defect, maybe because of the fibrosis, and coronary artery disease, pulmonary hypertension, and more incidence of DVT and or pulmonary embolism and congestive heart failure also. The other effects on the other systems are respiratory, because of the weight it acts as a restrictive kind of lung, restrictive kind of disease for the obese patient. These people has a hyperinflammatory situation, and they're prone to allergy, and they are having asthma, sinusitis, spectrum of disease, and also, as I mentioned, in OSA, and also OHS, obstructive sleep syndrome. Then cardiovascular is already discussed. Endocrine, there may be type 2 disability, type 2 diabetes mellitus. Cushing's and hypothyroid is common, and there may be hyperlipidemia, and from liver changes, there may be some vitamin deficiency. In gastrointestinal, there may be commonly hiatal, inguinal, or umbilical hernia. There may be fatty liver in different stages, and gallbladder stone is common. Musculoskeletal, excess weight bearing leading to osteoarthritis and low back pain. There may be association with some malignancy like breast is more common in obese patients. Cervical cancer, uterine cancer, colorectal, and prostate is commoner. And in psychiatric problems are depression and low self-esteem. This is a British Journal of Surgery publication on 5th January 2020. It's a array of all system involvement with risk index, like hypertension. If I compare with non-obese patient, odd ratio is 4.8, and the heart failure is 1.9 for male, and female 2 point something. Ischemic heart disease is 1.6, myocardial infarction is 2, atrial fibrillation is 1.5, diabetes relative risk is 7 times higher, and dyslipidemia is 2.2. Metabolic syndrome from like stroke and myocardial infarction and atrial fibrillation, again, there may be hypercoagulability, so stroke and myocardial infarction, deep vein thrombosis and pulmonary embolism is 2.2. About renal disease, the two contribution from hypertension and type 2 diabetes mellitus, both is almost 1.5. Now I'll go to some basic physiological things, like this everybody knows is the oxyhemoglobin dissociation curve, shift to right and shift to left. When there is a CO2 buildup, there is maybe a shift to right, and the lower part of the curve, more oxygen can be delivered to the tissues. And one thing is this: is as it is a sigmoid, there may be a jump, fall, or sudden drop from below 90, as if there is any episode of hypoxia or inadequate airway maintenance. This is a comparison of pre-oxygenation. The first thing is a 4 minute deep breath, 4 deep breaths in 60 seconds, and this is 8 vital capacity breaths, and this is normal tidal volume breaths. So it's the time that saturation goes down to below 90. See, if there is 8 vital capacity breath, it is over 5 minutes, and if it is uh, 4 deep breaths only, then it can be almost half of that thing. So adequate pre-oxygenation, the importance of adequate pre-oxygenation is that if you consider the uh, what is called range of uh, range of maximum, it goes up to 6 minutes. This is a graph showing the as FiO2 is being increased, and uh, when there is apnea, to drop saturation to 50%, this is the time to drop. Say this is the buildup of the oxygen, but after 0.9%, that buildup is very high. So this is the place that we have to work on in an obese patient to build up that upward trend as a reserve for oxygenation. This is a graph where is the normal weight with 100% oxygenation. If properly oxygenated, it may be after zero expert volume, it may be 10 minutes, that saturation goes down to below 50. But if it is a obese patient like 127 kg, if it is within 4 minutes, it will desaturate dangerously. And this is a normal 10 kg child having less FRC. It is also almost same as an obese child. And if the patient is a 70 kg but moderately ill, say having high fever, those patients also will fall down within 6 minutes. If a suxamethonium, 1 milligram suxamethonium is given to intubate, and if we cannot intubate, say, then suxamethonium will recover 6.8 minutes. It is 10%, and it will be 10.2 minutes when 90% Saxa will be recovering. So even with Saxa, if adequate oxygen level is not built up or adequate support could not be given, then patient will be at risk. The patient factors, now we'll discuss some of the patient factors that may affect the efficacy and efficiency of pre-oxygenation. In obese patient, there is reduced FRC. There may be atelectasis, and tidal volume may fall within closing capacity. So there may be already a collapsing tendency. So there is less efficacy and less efficiency. By efficacy, I mean is time taken to achieve end-tidal oxygen of more than 90%, and by efficiency, we mean the prolongation of the safe apnea time. That is how late it goes to drop the saturation. The other things like pregnancy and okay.